of discussions. I got it. So the topic tonight is a very informative topic. It is about radiation protection principles and policies. And our speaker is Mr. Mukesh Jain, who is from SMS Medical College, Jaipur. It is with the collaboration of GAPIO with Global Association of Radiological Technologists of Indian origin. And our moderator tonight is Dr. Vinita Sharan. Vinita is a senior radiology consultant at Deep Tech Medical Services. She is adjunct faculty public health at Foundation of India. And Vinita is also a former associate professor San Beda College of Medicine in Philippines. And briefly, one more thing about Dr. Vinita. She is advisor radiology of the CMEs for GAPIO and is very instrumental in organizing the virtual sessions of GAPIO. And congratulations, Vinita. This is your 6th session under your mentorship. So with this brief introduction, welcome everyone, and let us start the session. Thank you. Over to you, Dr. Vinita.
Yeah, thank you very much, Dr. Anju Agarwal. That was very nice of you. And hello, everyone, and greetings of the day to you, wherever you are, in whichever part of the world you are in. I would like to request you at the start of the session to put your queries in the chat box below. And as you know, the topic for today is radiation protection, principles and policies. While this topic is of great importance to the radiologists and the radiographers and all the radiology technologists, it is also of immense value to all the doctors and the physicians who request for these studies. So everyone should be aware of the risks and benefits of these imaging studies. So if I remember, radiology is for radiologists and also for radiographers, sometimes radiation protection is a very neglected topic. So I remember as residents and fellows at the start of the year, we would be given a dosimeter, which was supposed to be worn all the time in the hospital. But the truth was that for most of the time, the dosimeter would either be sitting at home or in the bag, and very occasionally be worn on the white coat. And we were supposed to have them evaluated every 6 months. But the evaluation, if ever done, the reports were never given back to the residents. So it really made it meaningless to have these dosimeters. So I'm sure many of you would relate to it. I mean, this happens very often. So to emphasize or re-emphasize the importance of radiation protection, we are having this session today, and we have a very eminent speaker to give us information on radiation protection, the principles and policies of this. And I think Dr. Sunil is here. So I would like to introduce our chairperson for the day, Dr. Sunil Kumar S. He is working with Regional Cancer Center Trivandrum as technical officer in the Division of Radiation Physics since 1990. Dr. Sunil is presently the Secretary Operations of Indian Society of Radiographers and Technologists. Dr. Sunil has delivered several lectures on the topics related to radiation physics and therapy. So I now would like to invite Dr. Sunil Kumar to give to introduce our speaker for the evening. Dr. Sunil.
Dr. Sunil, we are waiting for you. Are we audible to you? Dr. Sunil?
Okay.
Dr. Sunil?
Seems we are not audible to him.
Yeah, I think we are not audible.
Dr. Sunil, can you hear us?
No, I don't think he's able to hear us because there's no response from him.
Should we call him?
Yeah, Jiten, can you call him once? Probably he's not getting the audio.
Dr. Sunil, I have already introduced you. Would you like to start? Introduction of the speaker.
I don't think he can listen us.
So I think we can continue
Maybe-
with talk, and meanwhile we'll try to get in touch with Dr. Sunil.
Okay, so I think I have a brief introduction of Mr. Mukesh. I will just give it here. Dr. Mukesh Jain, he is working with SMS Medical College and is attached to this hospital in Jaipur. He is a senior radiographer, faculty cum research scholar, working as academic in charge of BRT, DRT courses in paramedical institutions, SMS Medical College, Jaipur. He has done a lot of work on research. His qualifications mostly are, he is actually pursuing a PhD in paramedical science from Jaipur University of Health Sciences. And he has done his MSc in radiotherapy technology and radiation technology. He has been the fellow of ITP 2005 from EHSAL, European Institute of Higher Education, Brussels, Belgium, and STI 2014 from EHSAL, again, European Institute of Higher Education, Brussels, Belgium. He has received a number of awards and his achievements from the American Society of Radiology, Shape Your Skills Award 2019, RUHS Scholar Travel Grant in 2019, Radiographer Ratna in 2018, Outstanding Service Award in 2019 from SMS Hospital Jaipur, Outstanding Service Award in 2018 again from SMS Medical College Jaipur, and VLIR Fellowship from Belgium by the Belgian government in 2014. He has membership in many of these professional organizations: ESR, ESTRO, ISRT, IART, and ARTTI. So, Mr. Mukesh Jain, may I now request you to give your talk?
Yeah, good evening all. Am I audible?
Yes.
Yeah. It's thank you, Dr. Vinita, for a nice introduction. And I take this opportunity. As my slides are visible?
Yes, I think you have to put it on full screen mode, I think.
Yeah. I did it.
I don't see the full screen.
It's now visible.
No, still not. We can see, I think your screen is not getting full screen. Slideshow is
Yeah.
not starting yet.
Mr. Mukesh, try pressing F5. It will put it in the slideshow mode. Yeah, perfect.
Yeah.
Is it okay?
Yes, Mukesh,
Yeah.
fine. Thank you.
Yeah. Thanks. So I take this opportunity to thank the organizers to provide me opportunity to discuss the rationale as the topic of radiation protection principle and policy framework is very wide and involve the safe use of the radiation professional practice throughout the century. The radiation existed on the earth before life emerged. In fact, they have been present in space since the beginning of the universe, and the radioactive materials was part of the earth as its very information. But the humanity first discovered this elemental universal phenomena only in the last years of 19th century, and we are still learning new ways of using it. So we interact with the radiation in our daily life in various means. So the radiation is used as a radio spectrum, as a microwave. You will see that as a infrareds, invisible lights, ultraviolet lights have the low wavelength and high wavelength and low frequencies, and energy is termed as a non-ionizing radiations, having very low impact on the biological system, while the radiation used in the medical field or the industrial field like X-rays, gamma rays, and cosmic rays termed as ionizing radiations, having the high frequency and high energy, so causing high impact on the biological system. The radiation doses received from various activity, either the natural in form of terrestrial or in form of the cosmic rays, food, weed are the buildings and the man-made by the artificial sources of the radiations, including the medical exposures, starting from right from microsievert amount of doses. So it may come to surprise that the sources of radiation causing the greatest exposure of general public are not necessarily those that attract the most attention. In fact, the greatest exposure is caused by the natural sources or ever present in the environment, and the major contributor to the exposure from artificial sources is the use of radiation in medicines worldwide. So moreover, everyday experience such as air travel, living in the well-insulated homes in certain parts of the world can substantially increase the exposure of the radiations. So to understand the effects of radiations, we should recall the pioneers of the radiation science introduced earlier. Vial of radium that Henry Becquerel put in his pocket damaged his skins. William Conrad Röntgen discovered the X-rays in 1895, died of cancers of intestine in 1923. Marie Curie, she is also exposed to radiation throughout her working life, died of blood disease in 1934. So it is reported that by the end of 1950, at least 395 early radiation workers, mainly the doctors and the other scientists, had died from the exposure to the radiations, unaware the need for the protections. So those evidence put the stress on the community to work upon to identify the effect of radiation on the biological systems, expressed in three ways in terms of external radiations, the contamination with the radioactive materials, and incorporation of these into the body system or the organs. So the sources of radiation and the basis to develop this knowledge and the policy for the system of protections of humans is based on the use of reference anatomical and the physiological models for assessment of the radiation doses, biological studies at the molecular and cellular level, and the experimental animal studies on the micro mechanism or of the carcinogenesis and the heretical epidemiological studies. The United Nations Scientific Committee for the Effect of the Atomic Radiations, UNSCARE, conducted the comprehensive review of the occurrence of the cancers. So in population, the exposed radiation, and they estimated that the additional chance of dying cancer due to the radiation exposure above 100 sievert was about 3 to 5 in the hundreds per sievert. So other organizations like ICRU, IAEA, NCRP, IEC, and in India, the AERV is working upon the various aspects of the formulation of the recommendations for the professional practice. So the aims of these recommendations is to contribute an appropriate level of protection for the people and the environment against the detrimental effects of the radiations exposure without unduly limiting desirable human endeavors and the actions that may be associated with such exposures. So the objective is to manage the control exposure to ionizing radiation so that the tissue reactions are prevented and the risk of cancers and the heritable effects are minimized for the humans, and to control the exposures to ensure negligible impact on the environment. Thus, the basic principle of radiation protection involve a justifiable exposure, the ALARA, and the dose limits. So the justification in the practice is that the entails exposure of the radiation should only be adopted if it yields significant benefit to the exposed individual or the society to outweigh the radiation risk. So for examples, in radiation therapy will not use for the pityriasis versicolor or the thyroid goiter for these treatments. The pelvimetry is not suggested used nowadays routinely, as it has significant hazards for the fetus, although it may be useful for the rare mother or some pelvic deformity. So the basic principle for the ALARA express that the radiation sources and the installations should have the best available protections and the safety measures under the prevailing circumstances, so that the magnitudes and the likelihood of the exposure and the number of individuals exposed be as low as reasonably achievable. So the economic and social factors being taken into the account, and the dose they deliver and the risk they entail to constraint. So protection and safety should be optimized. So looking upon, we can easily find out the safety specification. Safety specifications differs from one practice to another practice. The safety specifications may be not enough for practice in interventional radiology. Here we see in the picture, and might be enough for working in the diagnostic radiology, like this protection is okay for this kind of source of radiations, while these protections we want, say, it's optimal to be protected from these radiations. So the optimization of the process also involves the selection of the modality. For example, in obstetric, X-rays or the CT scans better replaced with the clinical examination of the sonography, MRI, and CT scan. CT is the one of the major contributor of the radiation doses, accounts 25 to 40% of the medical exposures, and the study reveals that the child undergoing for CT examinations are having higher risk probability than the adult due to the higher life expectancy. So the process of optimization of radiation practice can be achieved by following these three cardinal values, that the minimize the exposure time, maximize the distance from the source of radiation during the practice, and use of appropriate shielding. The radiation protection practice can be planned in the following ways. So the use of the use of exposure factor in the radiography, using of high kV techniques involve less side scatter and result in low radiation doses for the radiation professionals. The modulation of MAS in CT procedure was found to be reduction in 16 to 18% of the radiation doses. Similarly, the amount of collimation while using the radiation sources is also found to be useful during the professional practice. So here we can see the body posture of an individual undergoing in the radiological examinations, the position of the radiation source in the under couch and the over couch examinations. So we clearly see while using or fluoroscopy, keeping the tube downside will involve less amount of radiation to the professionals while using the X-ray source or the radiation source above the table will incur higher amount of radiation doses to the radiation professionals. The position of the radiation source is also important, and the position of the radiation professional or the physician performing the different kind of investigation is also very important to minimize the radiation risk. So we'll see that standing just opposite to the X-ray tube will involve lower amount of radiation doses as compared to the standing in front of the just behind the X-ray tubes due to the backscattered from the patients. Because for a professional, the patient or the individuals undergoing the examination is the source of radiation instead of the generator of the radiation. So you'll see in radiography of the extremities, the position of the individual undergoing radiological examinations can also be having great impact on the amount of radiation doses by the individuals. So there are various ways to perform a one examinations for the extremities, and that kind of examination and that kind of possibilities will incur lower amount of radiation doses to the individual also. So there are various means, and the shielding express the infrastructure and the individual designs of protections in terms of barrier thickness, locations, and the arrangements in such a way to minimize the transmission of the radiation should be less than 5%. So it's a different protective apparels or the protective apparels can be designed in this way, like gloves having 60 to 64% protections at the level of 50 to 58 kV, while eye protections provided by the lead goggles. Thyroid collar also help in reducing the side scatter and the aprons. So designing of the radiation facility is also very important to minimize the radiation risk to the individual as well as the professional performing the radiological examinations. So we'll see the common faults and fittings of the lead glasses. A small amount of leakage of radiation may result in higher doses. So better to cover it with the lead covering can be termed as a good shielding procedures. Also, the shielding designs should be in such a way that the radiations beam shouldn't be backside or the sideways, and it would be better if the operator stands perpendicular to the radiation sources. So it might involve lower amount of radiation doses due to its angular dependence of the radiations. So the use of radiation associated with the probability of the risk so as to quantify the amount of radiation and the concept of radiation doses was introduced, termed as the energy deposited in per unit mass and called radiation doses. Initially, the concept of radiation doses was introduced in terms of tolerance doses, explained by a certain amount of radiation doses are required to produce the biological effects, sounds in such a way that there is a level of radiation below it the safe doses. So minimum amount of threshold value will required to create some kind of biological impact on the tissue or the biological system. So that term as a tolerance doses, but based on the work of honorable genetician that H.J. Muller indicated that the reproductive cells were vulnerable to even smallest doses of the radiations, and the concept of radiation doses were abandoned, and the concept of the stochastic effects of radiations invalidated this dogma, and the concept of permissible dose is introduced in the picture. So in light of present knowledge, it is not expected to cause the appreciable bodily injury to the person at a point during his lifetime, and the acknowledgement that doses below maximum permissible doses have a probability of risk of stochastic effect of radiations, and it induced the concept of acceptable risk. The probability of radiation induced injury was to kept as low to be easily acceptable to the individuals. So the concept of permissible dose is introduced in the regulatory framework. Updating the knowledge of radiation interaction with the biological systems enable us to design the recommendations to provide appropriate level of protections for people, environment, as well as to predict the probable risk associated with certain practice, and the dose limits were formulated during the course of time by various scientific groups. So that's initially during initial phase of detection of radiations, the erythema dose acceptably universally as an impact of radiation on the biological system. Later on, it's introduced in various forms, in form of fogging on the film or the dental film, creating optical density of the film suggested by the Rollins. The tolerance dose acceptable initially during the period of 1920 to 1940 due to the deterministic effect of radiation. And during course of time in 1925, 100 of erythema dose or be suggested by the Sievert. So it's a gradual updating process taking place during the course of time, and the evaluation of the limits, those limits suggested by the various regulatory authorities or various scientific groups, initially by the IXRPC, that is Ionizing Radiation Protection Committee in 1928. It's suggested the 1 sievert per year for the occupational worker. Later on, IXRPC suggested that 500 millisieverts per year estimated threshold is later on converted into ICRP in 1951 or 1950, and suggested the 3 millisievert per week estimated dose. So in ICRP 1966, they recommended 50 millisieverts per week for workers and 5 millisieverts for the members of the public. While in ICRP 26 in 1977, they suggested 50 millisieverts per year for the workers and 1 millisievert for the general public. Later on in ICRP 16 and ICRP 103, during the updating knowledge and different studies taken place during the course of time, updated the amount of radiation doses should be kept below the permissible dose limits, termed into in form of 20 millisieverts for the radiation worker and 1 millisievert for the members of the public. So the system of radiological protections was evolved for the type of category of the exposure for the individual exposures or the different type of exposures. So in case of plant exposures, occupational exposures defined in form of dose limits and dose constraint. Public exposure is also defined in terms of dose limit and dose constraint, while the medical exposures should be kept below or equal to the diagnostic reference levels. So reference levels are also created to guide the maximum limits of the amount of radiations, varies from place to place, should be identified, and the practice should be followed in such a way that the amount of radiation doses delivered to the individual should be kept nearby to the diagnostic reference levels. So emergency exposures also having reference levels for the occupational worker and also for the public, and there is not attached with the medical exposures as the individual is beneficiary from the test due to the justification process. So no radiation dose is safe dose. However, the radiation is the boon to mankind, and if we use with the caution and the following the principles and of the protections and making policy protocols in professional practice, so definitely it will outweigh the risk, and we can use the radiations for our daily day-to-day practice with the using different policies and protocols. So I'll thanks all for patient hearing.
Thank you, Mr. Mukesh Jain, for this very informative information on radiation protection. I have one question to you. What is the policy that we follow in India? Like, do we have a system where we regulate the amount of exposure to the patient? Also, I think the patients waiting in the outside the examination room, waiting for their turn to go through the radiological procedure. So what do we follow here in India? Like, you have to unmute yourself.
Sorry.
Yeah.
It's okay.
Yeah.
Yeah. In India, that's we have the regulatory body termed as AERB, Atomic Energy Radiation Regulatory Board. So that they used to import the suggestions from the ICRP and the IAE, and they defined the dose constraint and dose limits for the professional worker and as professional practitioners, and also for the general public. So it's term defined as in form of 20 millisieverts in a year for the professionals can be maximized into 30 millisieverts with keeping 100 millisieverts for a 5-year block, while for public it's 1 millisieverts. And the amount of radiations defined for the patient is as I expressed that we developed the system of radiological protections, introducing the dose reference levels depends on the modality, what we are using, what kind of techniques we are having. Either we are using the digital radiographic systems or the conventional radiographic systems or the CT scan or different kind of exposures, and what kind of technical parameters varies from one local place to another local place. So every local place can frame a guideline or can make a policy to identify the least minimum amount the radiation doses, that is provides least amount of radiation doses with acceptable levels of diagnostic values in the radiological procedures in form of diagnostic reference level for the patients.
Okay. And then, so I would guess, so sorry, just a follow-up question. So I would guess we would have procedures in place to keep monitoring the radiation in the department, right?
Yeah, in major cities now we see due to the technical advancements, many of the systems like CT, and they are all having the DMS, the dose management software inbuilt in it. Some of the machines, digital systems are having the DAP meter, that is dose area product meter, inbuilt in the machine. So they will provide real-time amount of exposures received by the individuals in form of real-time calculations or by the way of Monte Carlo simulations, or the mathematical calculations can taken place with the use of the computers. But right in village area or the rural area, the system is lacking. So might be updating during course of time, and in future we'll see that the updated database and knowledge will have in future to identify the amount of doses incurred with the various radiological examinations.
And I think hopefully all the old system X-ray machines and CT scans would eventually be replaced, I think, with the newer machines which are more efficient and less hazardous for the patient as well as the radiographers and radiologists. So
Yeah.
yeah.
So
Okay. Thank you very much. I think there are some questions in the chat box. One of them is, what does erythema dose mean? I think states for. So someone
Yeah,
has asked.
erythema dose, its term initially when the radiation is discovered by the Röntgen, and the use of radiation started in many fields, even in the medical fields, in the beauty parlors, in the watchmakers, in the in the industries in form of shoemakers. So though, and even in the trichoscope, that the movies they are playing to see the internal structure of the body. So vast use of these radiation is initially starting the reacting by the biological system in form of skin reactions. So it is termed as erythema. So initially when the erythema started, or a certain amount of radiation doses received by the individuals, the skin react in form of erythema, initially in form of dry erythema, and later on converted into the wet erythema. So by seeing the skin tone and the arithmetic effects, we'll guess the amount of radiations, and these amount of radiation term as arithmetic doses.
Thank you.
Is this the answer of your question?
I'm sure you have answered it correctly for the erythema dose. So I would guess this person who asked the question would also be satisfied.
Okay.
So
Okay.
there's another question. Someone has asked that recommended 0.05 REM for embryo, fetus, and once pregnancy, known it's not greater than 0.05 REM, excluding medical exposure. So, sir, presently, what is the protocol in other countries? Please share their dose limit. We have to explain to our female radiographers. So I think probably asking what is the exposure dose for pregnant women.
Yeah, pregnant women, the radiation doses defined in two ways. As the pregnant female having the fetus in it, and the fetus is termed as a general public. So we'll keeping in mind that the amount of radiation doses received by the fetus should be as equal to the general public, that is the 1 millisievert. So on the surface of abdomen, the pregnant female can receive the amount of radiation doses up to 2 millisieverts. So at the level of fetus, it should not exceed from 1 millisieverts as equal to the general public. That is the guidelines mostly adopted by the ICRP as well as the AERB for the radiation protection guidelines for the pregnant females.
I think there's one more question here. It says, according to references and opinion, what should be the threshold values for radiation hazards? Is there any? And if it's there, then please state, state the quantification of it. And what molecular changes does ionizing radiation do that causes stochastic effect to the exposed person?
Yeah.
So I think there are two questions.
Yeah. So the pardon, one is the
one, I think, is the molecular changes that happen because of the ionizing radiation for the stochastic effect.
And other one is the threshold doses.
Yes.
I think. Yeah. Okay.
Yes. Yes.
So yeah. So threshold doses, as I explained, initially conceptualized upon in between 1920 to 1940. So the threshold doses term as a certain amount of radiation doses is required to respond by a biological system in terms of varying kind of effects, might be cataract, will term as 150 millisieverts is required to create a cataract in individuals. Later on, updating of knowledge of the biological system, we get to know that even the small amount of radiation doses is also having very higher impact, depends on the reaction of the biological systems. H. J. Muller also insisted and identified the amount of genetic mutations in cells due to the radiations. It might be useful in very low cases, but harmful in many cases. So the radiation interact in various ways with the biological system, either in form of direct effect or in form of indirect effects. So indirect effects generally occurred in form of the formation of the free radicals into the human body system, and directly or indirectly, they indirectly both affects the structure of the DNA or the biological system of the cells, so that to create the certain amount of changes into the biological system. Once the amount of doses is reached up to a level that effects of these radiations cannot be reversed, is termed as a threshold value. And nowadays, by seeing the stochastic effect of the radiations, we'll see the small amount of radiation doses might have the probability to induce certain kind of radiation effects. So nowadays we are saying that no dose is a safe dose. We need to optimize our systems or practice to maintain our radiation doses within the limits of the probable risk.
Yeah, thank you very much for your answer.
Hello, Mukesh, can I hear?
I think
yes,
Mrs. Dr. Sunil is here.
Yeah. Actually, it's a very good presentation, Mukesh. But according to threshold dose, the latest theory is no threshold dose. Wherever there is a small bit of radiation, the effect is there. So the latest theory is no threshold dose. Actually, it is immaterial to deterministic and stochastic effects. So the latest theory is no threshold dose. If there is a little bit of radiation, then definitely there should be an effect. That is the thing. Thank you.
Yeah, so I also told that the threshold dose concept is abandoned, and it's now taken place in form of maximal permissible dose. So that entails the amount of radiation risk and the probability of the radiation risk in it. So no dose is the safe dose, we are saying nowadays.
I think I just have one last question. We have so many different radiations happening to us all around. So what is the proportion of the medical related radiation dosage compared to universal dosage that we get from the solar system and otherwise?
Yeah, so right now in present situations, we are having the contribution of radiation doses by the natural sources in higher amount, although the medical exposures accounts for 50 to 60% of the radiation doses to an individuals. And in medical exposures, the maximum weightage of the radiation doses incurred by the CT examinations ranges in between 25 to 40% of the radiation doses of the total medical exposure doses. Interventional radiology is also the one of the procedures incurred higher amount of radiation doses to an individual among the medical exposures.
Okay, I think we have come to an end to the questions. I think how should MPD per year? I'm not sure what's that person is asking. Maximal permissible dose. I think you've already talked about it. No dose is safe. So
dose.
Yeah.
But
so,
to keep our practice, we need to decide certain amount of doses should be kept within these values for an individual professional as well as the individuals.
Also, what would be the difference between CT that we do colonoscopy. And then we used to do the barium studies earlier, barium enema and barium upper GI series and all. Between those studies and CT colonoscopy, which would be more damaging in terms of radiation?
Yeah, if we go with in terms of radiations, barium enema by the conventional process, we used to use the fluoroscopy. So
Yes.
fluoroscopy depends, the amount of radiation doses received in the fluoroscopy depends by the professional doing the examinations. If one likes to use the fluoroscopy on for all the times during the process, definitely it incurred a higher amount of doses. But if an ideal practice or ideal practitioners, we compare presently the IR systems and the CT scan systems, the CT is having higher amount of exposure values, and the amount of images taken by the CT scans is much in higher amount. So the dose values in CT colonoscopy is much higher. So the comparison depends on the
Operator.
operator or persons doing examinations, what he's like to do, whether he's like to see a movie in fluoro.
Yeah, also
So,
collimation is
yeah.
very important doing the fluoroscopy.
Yeah, collimation is playing a very important role. As we and the CT has having the pre-patient collimator and the post-patient collimators, so that confined the radiation is confined to a certain area. So they are having the limiting factor of the radiation doses, but the comparison again depends on the use of practitioners, how we are using both modalities.
And also, I think the generation of the CT machine. Which generation of
Definitely.
CT machine you are using? Okay, I think.
Yeah.
So I think, Mr. Mukesh, thank you so much for such an informative talk and also answering all the questions that we have. I think I have put up a lot of questions to you, and you have answered them very nicely and very clearly. So I thank you very much for the talk, and I will now invite Dr. Sushil Jain. He is our GAPIO's honorary advisor to give the closing remarks. Dr. Jain.
Thank you, Dr. Vinita. So before I bring the session to close, I think Dr. Sunil is now available and we are able to hear. So if there are any comments from his side, he was supposed to be the chairperson, but unfortunately due to some technical glitch, we were not audible to him. So Dr. Sunil, if you are still there in the call, any comments from your side?
Thank you. Thank you. Actually, I'm really sorry because of a network problem and I couldn't hear the audio. That's why. I'm really sorry because it was a technical problem. Anyway, it will not repeat it. Anyway, yeah. Thank you because hi, Dr. Actually, the topic is very relevant because most of the people working in medical profession, most of the medical professionals doesn't know the radiation hazards and how to use it properly. So it's a relevant subject. Anyway, Mukesh Jain could answer all the queries of and all the doubts people who are working in this area. Anyway, it's a nice presentation, and thank you very much. And please proceed with the other things. Thank you.
Thank you, Dr. Sunil. So before I bring the session to close, I'll like to thank once again to Dr. Vinita, who has done all the backside work to bring this session to the platform. Dr. Anju Agrawal, who has joined all the way from Australia at a very odd hour. It's around 12:30 now in the night. And the speaker, Mr. Mukesh. So thank you, all of you, and thanks to all the people who have worked behind the scenes regarding the IT and Jitendra to coordinate all these communications. Thank you, everyone. Have a good night. Thank you.
Yeah, thank you. Thank you, Dr. Anju, again.
Thank you, Dr. Anju.
Yeah. Thank you.
Thank you, sir. Thank you, GAPIO
Thank you.
and GASHU, to provide
Thank
me
you.
opportunity.
Thank
Good
you,
night.
Mukesh.
you.
Nice
you,
to meet
sir.
everyone. Good night.
Yeah.
Good night.